ايوه ايوه ان شاء الله. طيب بدأ الشباب التسجيل الآن. طيب بسم الله الرحمن الرحيم، الحمد لله والصلاة والسلام على رسول الله وعلى آله وأصحابه أجمعين. شرفتمونا دكتور يوسف الناصر، دكتور أطفال، له أكثر من 30 publication، واشتغل مع عدة منظمات دولية في صحة الإنسان مثل Save the Children and يعني أطباء بلا حدود. تخرج من عدة جامعات واشتغل في عدة مستشفيات كبرى. الدكتور يوسف أراد أن يفرغ من وقته وعلمه من أجل نشر يعني شيء من تجربته وشيء من الأبحاث التي قام بها. نتشرف بكم. نشكر أولا الشركة الراعية شركة هيمالايا، ومعكم زملائكم في اليمن دكتور أحمد هدنة رئيس مشروع تو بي فيت فور بيدياتريشن. هذا مشروع خيري عملناه من أجل تقديم خدمات لأطباء الأطفال، والحمد لله نجد تفاعل من كثير من الأطباء داخل اليمن وخارجها في المشاركة في تقديم المعلومة الطبية بأيسر طريقة للزملاء. مرحبا بكم دكتور، والمايك لكم دكتور.
شكرا، أنا يعطيك العافية، شكرا على المقدمة الجميلة. I think إنه عشان الأغلب يتكلم عربي I'm gonna do إنه أغلب البرزنتيشن بيكون بالعربي. ممتاز ولا you guys تبغون إنجليزي شوي هنا وهناك؟ أيهم أنسب. طيب صوتي واضح؟ الصوت واضح؟ لا يضل عليكم. Okay. Okay, so a lot of people got English واضح, clear. Okay. So we can do both. We can do a mix. So we can do Arab English. So a little bit here, a little bit there. نسوي الاثنين. ف طيب do you see my slides? أنا إذا حطيت إذا if I put it as a presentation, I wouldn't be able to see the chat. So if I will leave, okay. All right, how about now? You see the slide? Okay, good. طيب, so I'll make it like this. I will be able to see the chat at the same time. طيب, so I don't have anything to disclose. ما يعني هذا عن طريق أول شيء نشكر الدكتور حسن باتيس who was the connection مع الزملاء. thank you for allowing me to come and talk to you. وإن شاء الله إنه يكون خفيف ولطيف and we learn from each other. I'm not getting paid to give this talk and I have no conflict of interest. طيب خلينا نبدأ بالأول. Why do children die in low income countries؟ الحين يمكن اليمن الله يحفظها ويردها سالمة غانمة إنه تعتبر دولة نامية ومنطقة نزاع. why do children die in low and middle income countries including Yemen؟ طبعا نقول نتكلم why die يعني ليش الأطفال يموتون قبل سن ال5 سنوات. So what do you guys think؟ وش أكثر سبب يخلي الأطفال يموتون؟ What is the number one cause that let children die before they reach their 5th birthday؟ تقدرون تكتبون بالchat or you can say it. Unmute yourself and say it. So this is going to be an interactive session, so please لأنه مع الزوم الواحد يكون سهل عليه إنه okay. So a lot في ناس كثير gastroenteritis or diarrhea. Yeah, diarrhea used to kill a lot of children in the past, بس ما هو زي أول. Now خاصة بعد الروtavirus vaccine, the numbers of children dying from diarrhea is way low. And if you see here, diarrhea now is only 8.5%. Sepsis is a good thing, but we see less sepsis now because مستوى النظافة ارتفع والتطعيمات. Yes, sepsis is a good. Injuries, not as we used to say. يمكن مناطق النزاع تختلف شوية، لكن الانجريز are contributor، خاصة الحوادث السيارات، ولأنه people don't wear seat belt أو إنه يلبس دبابة no helmet. This is not as bad as preterm birth. That's a good one. Okay, so and postpartum complications. So the majority زي صح عليكم يعطيكم العافية. Now we actually made a huge gain في الصحة العالمية عموما, and we don't see children dying from sepsis and from TB or malaria or HIV as we used to see 15 years ago or before 2015. مع الجهود العالمية كلها إنه now it's actually neonatal causes is the biggest reason why children die, and neonatal causes are تقريبا وصلوا حوالي النص, almost 46%. 46% of children dying under the age of 5 actually dying because of neonatal causes. So we know that all the gains we have made in other areas left us, now we have to focus on neonates. We have not made a huge effort in the past to try to save the neonates. لما نناظر على أفقر منطقة في العالم اللي هي Sub-Saharan Africa, we want to know المنطقة ما تحت الصحراء الأفريقية. We want to know why do children die while they are neonates. طبعا أكثر شيء هو الخدج أو prematurity. So prematurity is the number one, تقريبا 52%. بعدها يجي birth asphyxia, بعدها يجي sepsis. So neonatal sepsis is number 2, which is close to 25%. بعدها يجي birth asphyxia or HIE. Those are close to 14%. Then other issues like congenital malformations, other causes are still present. لكن خلينا لو we want to focus on Yemen itself, what do you guys think? Why do neonates die in Yemen? This is a study that was done in Yemen recently in 2023 from a group that works مع الأطباء بلا حدود في مستشفى عبس General Hospital. عبس General Hospital. Sepsis preterm, yeah, that's good. So prematurity is the number one. It's close to 50%. And yes, yeah. So prematurity number one, close to 46%. بعدها sepsis is 20%. بعدين birth asphyxia is 15%. But it's similar to الأرقام حقت Sub-Saharan Africa. It's still prematurity. So anytime we can prevent prematurity, that would be a huge gain for us. We're still dealing with sepsis. Sepsis is a big factor of why do neonates die في اليمن. طيب هل تعتقدون انه الحرب ومنطقة نزاع لها دور في إن السبسس؟ Is there a link between انه لما تكون منطقة نزاع والامراض المعدية؟ yes صح. الكل يتفق. احنا نعرف انه whenever there is a war or a conflict there is infectious diseases. يعني الله يحفظ السودان قبل الحرب. Sudan, their cases of HIV was very low. Now it's increased by 200%. And the reasons are many. And conflict makes disruption of healthcare. فما يصير ما في vaccines. لما يصير ما في vaccines also يصير أيضا healthcare system نفسه يكون ضعيف. antibiotics not available. فيعني there is so many complications because of the war. فإن شاء الله نقول الأرقام باليمن ما تصعد أكثر وأكثر من ناحية النيونيتال سبسس. طيب the good thing عشان ما نكون سوداويين إنه let's be optimistic إنه الحمد لله إنه the global neonatal deaths حول العالم, all the world, it's actually declining. The number of neonates dying are going down. لكن at the same time, تقريبا 60 African and Asian countries are unlikely to achieve the Sustainable Development Goal, which was put together by the United Nations and by agreement by all the United Nations members. Does anyone know وش الجول حق United Nations Sustainable Development Goals? What number of neonates should each country reach by 2030? الجول انه we reach less than 12 neonate deaths less than and per 1000 live births. فإنه يكون أقل من 12 لكل 1000 مولود. اليمن is not too bad compared to sub-Saharan Africa. يعني مثلا أنا أشتغل في Ethiopia their numbers is close to 56%, while اليمن is 21 deaths per 1000 live births. فهذا يعني إن شاء الله إنه مع جهودكم وجهود الزملاء الموجودين والجميع وجهود وزارة الصحة والبرامج التحتية وأهالي اليمن إنه the numbers keep going down and down. But 21% despite the war is a number all of you should be proud of. Then compared to other countries is not considered as bad. هذا دليل إنه الجهود الصحية متميزة في اليمن. إحنا نعرف إنه neonatal sepsis is a systemic disease, is usually caused by bacterial infection. It can be in one site, it can be in multiple sites. قد يكون pneumonia, it can lead to meningitis, UTI or bacteremia. It can be occult, يعني ما إحنا لاقين وين. And only present with temperature instability, which is either more than 38 Celsius or less than 35.5. But despite that, it can lead to serious consequences ومنها الوفاة أو الإعاقة, cerebral palsy as well. And I'm sure all of you know that. أغلب ال neonatal sepsis actually happen in low and middle income countries. And between 2009 and 2018, the incidence was 3,930 cases per 100,000 live births. يعني من كل 100,000 في حوالي تقريبا 4,000. وهذا يعطينا انه estimated close to 17.6, close to 18% of neonatal sepsis cases that happen في الدول النامية للأسف انتهي فيها الحالة بالوفاة. هذا يعني انه 1 out of 6, واحد من كل 6 neonates who get neonatal sepsis they usually die if they happen to live in a low and middle income country. estimated incident mortality للneonatal sepsis في الدول النامية غالبا أكثر مع early onset neonatal sepsis. وفي دراسات كثيرة قالت if you make sure a neonate survive the first 2 days in a low income country or a middle income country, your likelihood of the neonate surviving is high. The most critical is the first 48 hours. يعني أول 48 ساعة. If you manage to save the child and do kangaroo care and make sure that the child is covered with antibiotics, they have temperature instability, the right antibiotics, then your likelihood of saving that neonate is high. And we know neonatal sepsis. Does anyone know what is the definition of neonatal sepsis, early neonatal sepsis? What is the time frame? ما هو الوقت اللي نقول هذا early ولا late? What is early neonatal sepsis? What is late neonatal sepsis? Time wise. إلى أي يوم نقول 72 hours. Okay. 72. That's early. Okay. So up to 1 week, yes. So we used to say only 72, but it's up to 1 week. That's an early onset sepsis. Yeah, 7 days. So up to 7 days, we say early onset sepsis. الأسبوع الأول, it's early onset sepsis. It's very critical if it happens in the first 72 hours. إذا حصلت في الثلاث أيام الأولى that is worrisome. إذا حصلت متأخر that is late أكثر من 7 أيام, this is late onset. طب late onset, is it up to 30 days or it can be a little bit more than that? إلى متى؟ طب من late onset is out of more صح يا دكتور. Up to 60 days. Up to 60. طبعا لما نقول if it's premature babies we have to calculate من ال corrected age. يعني مثلا لو واحد جاني 24 weekers يمكن يوصل عمره 4 شهور and he's still at risk of neonatal sepsis because he was born way too early. For premature babies it's always you're going to do the corrected age. لما نناظر early onset sepsis, do you guys have an understanding or from your observation, what is the most common organism that you see in early onset sepsis and the Yemen? مثلا في US we usually worry about GBS. Yeah. And لما كنت في السعودية there was a big debate. Does Saudi women have GBS ولا لا? And what do you guys think? هل تعتقدون إنه ال GBS is more common in the Western society أو المجتمع الغربي أو إنه it happens also في المنطقة العربية؟ Do you see GBS a lot في اليمن؟ For neonatal sepsis? الدراسات في السعودية كان في الأول قبل لما نتكلم عن نتكلم عن قبل 2015 كان في big denial إنه we don't have GBS, so despite the small study that looked into it and said the numbers are low and they were thinking because لأنه أغلب ال women في السعودية they are in monogamous relationship, they're only with one man, but later studies found actually the rate of GBS among Saudi women is similar to the rates in the United States, and it has nothing to do with the number of partners for a woman. So GBS is as common as close to 20% of the general public. That is in the rich nations, the GBS is very important for the early onset sepsis, but we also have to think about E. coli sometimes, and we have to think about Staph aureus. Late onset, usually you're going to think about then it can late onset غالبا إنه hospital acquired. So you have to think about the gram negative. We have to think about Staph aureus or cons Staph aureus. And you have to think about Pseudomonas as well. For late onset, usually it's a hospital acquired or nosocomial infection. But that's the data from the Western world. Like لما نشوف in some LMIC, those are a little bit different. And gram-negative bacteria is actually going up and taking the lead for early onset sepsis, where especially Klebsiella is the dominant neonatal sepsis pathogens overall in LMIC. Either you're talking about India ولا تتكلم عن أتكلم عن مالي ولا أتكلم عن تشاد أو أتكلم عن نيجيريا. Klebsiella is the dominant. Do you guys see a lot of Klebsiella pneumonia in neonatal sepsis? هل تشوفون Klebsiella كثير؟ Yeah. شكرا دكتور أحمد. Anyone else? Do you see a lot of Klebsiella as a leading pathogens to cause neonatal sepsis? Yeah. So asthma, شكرا دكتور أشواق. Yeah, it's becoming the driving force for neonatal sepsis is Klebsiella. where we still see GBS and E. coli as a second line. لكن لما نيجي نتكلم عن early onset sepsis or late onset sepsis, that definition of the United States and other industrialized countries, it does not apply على global south أو على المناطق الدول النامية. Because Klebsiella is taken over both early onset or late onset. والمشكلة الأكبر is not the Klebsiella. It's most of those organisms are actually have antimicrobial resistance. And if we look into the data that coming from middle and low income countries, close to 70% or 69% are resistant to aminoglycosides, and close to 80% that resistant to third generation cephalosporins. Even the meropenem, there's a high resistant rate reported against these antibiotics from the Klebsiella and other gram negatives. But that is really worrisome. What antibiotic we need to use? Should we, and what guidelines should we follow? لكن قبل ما نتكلم عن الempiric antibiotics, let's talk about the risk factors of why some neonates get neonatal sepsis. This is a study that came from sub-Saharan Africa, looking into تقريبا من Mali, looking at why some women or some babies, some neonate get so low immunity. So that's a good low immunity. It doesn't have to be إنه عندهم HIV أو إنه is malnourished. فالmalnourished اللي هم small for gestational age, those are a high risk factor. Malnutrition, لأنه خلاص you lose all the immunoglobulins, you're immunocompromised, you don't have enough protein. Any other risk factor you guys want to think? Yeah, it's unfortunate إنه ما في screening programs في اليمن، لكن لعل القادمة أجمل بإذن الله. The future is bright. طبعا احنا الستديز اللي قالت انه advanced maternal age, any mother who is more than 35 years is at risk. Yes, a multi-gravid mom is at risk. The male, there is some studies that says male actually do worst outcomes and worst neonatal outcomes, because testosterone is a pro-inflammatory hormones, while estrogen is anti-inflammatory hormones. So usually, in general, male don't do as well as female when it comes to neonates when they get sick. Interesting, actually, one of the protective factors is mother education. If a mother is educated, actually the risk of neonatal sepsis goes down. And we believe that because mom would have a better health literacy, تكون معلومات طبية أحسن، فتروح مواعيدها وتحرص عليها وتاخذ فيتاميناتها, and she can carry the baby to the end, and she would be able, and an educated mom not gonna have baby every year. So the number of gravida will go down. لما يكون intrapartum لما يكون في حرارة, that is a risk factor, and has a high odds ratio of 2.7. If mom bleed during pregnancy, that's also a high risk factor. لكن في أشياء إحنا نسويها. We can see, we know that the minimum number of antenatal care to improve the outcomes for the neonate, at least 4. ما نحتاج إنه تسوون 9 كاملين, at least 4, and then the outcomes of the neonate will improve. يعني عشان نقول لين تتحسن الأوضاع, let's aim at least to make sure that our pregnant women and our community get at least 4 prenatal care. لكن في أشياء إحنا, there's things we do as a healthcare providers that increase the neonate risk of getting sepsis. The first thing is we don't wash our hand before we handle the neonates, and that is a huge risk factor for neonatal sepsis. The second thing, we sometimes want to expedite the delivery, so we keep doing vaginal examination for the mom. The more you do it, the higher the risk. And when we say, if we want a number, any vaginal examination more than 5, that will double the risk for neonatal sepsis. So there's things it's in us that if we do, we can protect our neonates from having neonatal sepsis. Right. We know that even in premature babies are higher risk. We know low birth weight, malnutrition. Born to HIV positive mother is high risk. هل تعتقدون إنه if the mother is positive but the baby did not get HIV, are they still at risk of sepsis or not? يعني a newborn is the newborn is exposed but not infected. Do they have a good immune system or not? Or do they still at risk of sepsis? Yes, they are still at risk of sepsis because you're correct. So those who are exposed but not infected, they're at risk because their immune system is numb. شيء ثاني هم immune system in the first 6 months they depend on mom, so whatever passed to them from mom is what they have. والأم بيكون خاصة لما تكون الأم الفاير لود حقها عالي, then her immune system will be very weak. So yes, so those exposed and not infected, they're still at risk of neonatal sepsis. طيب, let's go. Are you all familiar with the new American Academy of Pediatrics guidelines that came in 2022? The one that rely heavily on the procalcitonin and absolute neutrophil count for children older than day 8. قبل ما نشوف الالجوريثم حق American Academy of Pediatrics that is a little bit more conservative for United States, let me ask you, what inflammatory markers do you have access to for to help you with guiding your decision about neonatal sepsis? Do you have CRP? Do you have procalcitonin? Do you only rely on absolute neutrophil count? If anyone want to say it and kind of open, or you just say it in the chat. CRP, yeah. CBC, CRP. Yeah, I thought the same. لأنه أغلب الزملاء يعني where I work in Africa as well, ما بروكاسترون ما هو موجود. اللي صار مشكلته إنه if you have anemia wouldn't be accurate. الشيء الثاني, it takes ESR takes time for it to rise. Yeah, it rise late and stay up for quick. So you need CRB أحسن. Yeah, CRB is better for infection, but yeah. So the new guideline actually rely in the new marker that is more sensitive. It's more procalcitonin. Procalcitonin is very expensive, but it has a higher sensitivity and higher positive predictive value than CRB for neonatal sepsis. It does not work for older children sepsis. It's not as good sensitivity, as not good positive predictive value. بس الneonate, it has super good positive predictive value and has super good sensitivity. And it's what does that mean? معناته إنه إذا ما هو عالي, your likelihood of having the sepsis is low. فالalgorithm looks like this. يقسم الأطفال or newborns or neonates into different ages. It looks into between the day 8. طبعا any child less than day 7, we're going to do a full septic workup and cover them with antibiotics. After day 8 to day 21, they would ask you to be a little bit more conservative, and you can start with urine analysis, and you can start with CBC and procalcitonin, and you can send the blood culture. And the question about should you do the LB or not is based on your procalcitonin. And some people will say, I'll do the LB uncover. لكن بعد 21 days, they will ask you actually to focus on the Burkhardt and urinalysis CBC to decide, do you need to do the LB or not? And that's how the algorithm look like. So it's a little bit more conservative لأنه احنا هنا في أمريكا we struggle with childhood obesity, and one of the risk factors for childhood obesity أو السمنة عند الأطفال إنه unnecessary exposure to antibiotics early on in life, which is under the age of 2 months. So they are trying to be more conservative to avoid using antibiotics, so we not add more numbers to childhood obesity. But in the United States, the number of children dying under the age of 5 is very low. It's like only 7 children. I will encourage all of you to look into this. But what do you guys think? Do you think, are you comfortable? High platelets are a good phase acute reaction, but they're not specific at all. So if the child is actually in pain, they will go up. So they're not a good indicator for neonatal sepsis itself. So I would look either at we're going to talk about what is the best for low resource settings rather than at this new expensive glucositonin. But platelet, no, I wouldn't look. Actually, I would look at a newborn. I'm not sure if they have enough ferritin to begin with. I would look at mainly at the absolute neutrophil counts, because that is a more sensitive and a specific indicator for neonatal sepsis, and we have enough studies on it. طبعا احنا كلنا انه اغلب الدول النامية they don't have access to glucosone. It's new, it's expensive. It needs a specialized lab. لكن the CRP is available. Absolute band is good, but absolute neutrophil counts is actually more sensitive for neonatal sepsis than bands. But you're gonna look at the absolute neutrophil counts, and along with CRP, and that can be combined with fever more than 38.5, and those have been tested in low-income countries, and actually combined together can help you predict the neonatal sepsis risk and how to manage. اعذرونا بس شوي دقيقة. There is a big wave انه اذا طلع الcultures negative, when should we stop the antibiotics? Is 1 day enough? Is it 36 hours? Is it 48 hours? Is it 5 days? We'll talk about that later on, and we'll revisit, and we'll ask you guys what do you think in your settings. Like an absolute neutrophil count is something you guys need to start looking at. Then it's really a good indicator, and it's already done. انتم تسوون CBC, فالCBC يطلع فيه absolute neutrophil counts. لكن احنا نعرف انه incidence of early onset sepsis is 9 times higher in a newborn born to a mother with risk factor, either prolonged rupture of embrace, mom has a fever, and have higher absolute neutrophil counts more than 10,000 than those who have absolute neutrophil counts within normal. Interpretation of absolute neutrophil counts must take into consideration the neonatal gestational age and postnatal age. لأنه مع the premature babies, it's really hard to look into the absolute neutrophil counts, and you have to look into the whole picture. At the same time, you have to keep in mind and neutropenia less than 1,000 is very specific for early onset neonatal sepsis, compared to neutrophilia more than 10,000. But if you see a child who has a CRP that high, a fever, and the neutrophil count is less than 1,000, that's a newborn that you're gonna worry about a lot. البلاد culture sensitivity في اليمن لما مثلا جاكم a neonate جاء emergency room and has a fever and you did a septic workup, let's say day 10, I did septic workup, and then the neonate looks good. يعني بعد ما خلص septic workup, I start antibiotics. Then you didn't actually feeding well, and you observed, and there's no more fever. When should you stop the antibiotics? Do you stop it at the 24 hours? Do you stop it at 36 hours, 48, or you wait until 5 days when the culture comes back negative? دكتورة خديجة تقول إنه she will stop antibiotics at 24 to 36 hours and keep the child 1 day for observation to make sure no other complication happen or the fever doesn't come back. Anyone else? Three days? Okay. 3 days is a little bit, yeah. But at least you guys better than our colleagues in Rwanda when I gave the lecture, because they were adamant that we have to continue to 5 days. طبعا في a big wave in the US to stop at 24 hours and keep the child in observation, like saying, my God, Dr. Khadija, 1 more day and see if they do well. And that's for a well-looking child who had a fever. And the reason why, because blood culture sensitivity to detect an organism at 24 hours is 87.5. يعني إنه ما دام ما نما شيء على 24 hours, the likelihood إنه remain negative is 87.5%. That's a high number. لكن لما نصبر إلى 36 hours, يعني يوم ونص, it's actually 96%. And 48 hours is 99%. So أضعف الإيمان, I would not keep an antibiotic more than 48 hours. And the reason why we want to get off antibiotics, because we want to make sure in our community, we're not the one causing rise of multi-drug resistant. We already have enough. So we don't want to contribute to augmenting these multi-drug resistant to have more resistance. If I have a message today about the lecture is, please stop the antibiotic at 48 hours for a well-looking child that you actually observe for 48 hours and they did well, so we can prevent multi-drug resistant organism. الشيء الثاني من أكبر التحديات في الدول النامية إنه I'm gonna follow the American guidelines. اللابس يعني لما أطلب لاب أنا هنا بروكالستونيوم will take me an hour and I will get the result. لما كنت أشتغل في ليبيريا it takes تقريبا حوالي 4 or 5 hours عشان يجيني CBC مو ال CRB. I will miss the golden hour of neonatal sepsis. We know in any sepsis, the longer you wait, any additional hours you don't administer antibiotics, especially beyond the first 3 hours, the mortality rate increase 8% by hour. كل ساعة تأخر يزداد خطر الوفاة 8%. But the earlier the better. And that's why I don't think relying on labs and the lab colleagues to bring us back the result would be wise in a place where neonates are dying at high rates. لكن السؤال الأهم, what antibiotic that you should start if you suspected a neonatal sepsis? خلينا نسألكم, what is your empiric antibiotic in في اليمن? Do you follow WHO guidelines, which is ampicillin gentamicin? Oral, if the culture is negative, I would not switch to oral if the culture is negative. I would stop antibiotic altogether. Okay, ampicillin and amikacin. That's an interesting combination, and we're gonna talk about. There's a lot. You're not the only one, Dr. Sahar. There's a lot of people who would love to use amikacin. الاميكاسين بعض الدول ampicillin, cefotaxime. Yeah, some people like it for late onset sepsis in high income countries. We know that it doesn't work. And Yeah, I work with MSF. I'm aware of their guidelines, which is I don't agree with. Ampicillin, amikacin. Ampicillin, amikacin. There's a lot of people are thinking amikacin is good. amikacin سهل تحصلونه في اليمن. Amsivitaxin. هل الاميكاسين سهل ينحصل في اليمن؟ اوكي. طبعا ال WHO still متوفر. اوكي. هو الاميكاسين عيبه الوحيد انه اغلى. بعض الدول الافريقيه زي اثيوبيا ما عندهم اميكاسين. ال WHO still recommend ampicillin gentamicin, which a lot of people actually not following. In the United States, we do like what you guys said, ampicillin gentamicin, usually for early onset sepsis. For late onset, we'll add cefotaxime because we want to cover more gram negative along with not ignoring the gram positive. Then no staph could be a reason. لكن في الدول النامية we know إنه multi-drug resistant organism and gram negative are the driving force, so we have to question ourselves. Is ambentin or and cefotaxime are the way to go. There is a study that was done by Dr. Al-Muqdad, reported actually he was able and his team to lower the mortality rate when they use amikacin cloxacillin combination therapy. And their mortality rate went down, especially for low birth weight neonates with late onset sepsis. And they compare that to cefotaxime and ampicillin therapy. And the only one that worked for them, it was amikacin cloxacillin. But the big study that has opened a lot of eyes toward what empiric therapy should go. It's called the Bernard study. The Bernard study found no difference in mortality among patients treated with ampicillin gentamicin compared to biptazo-amikacin or amoxiclav amikacin. But when they look into cefotaxime and amikacin combination, that actually the only one that helped in the Bernard study to decrease the mortality rate. The problem is, cefotaxime is actually in the watch list by the WHO. What does that mean? And the WHO is encourage all countries not to use cefotaxime as a first-line therapy or empiric therapy. Then it's one of the few that we don't have a lot of resistance to. So we want to keep it as much as we can. Like amikacin has been thrown here and there because it's actually, despite this being aminoglycoside, it actually has a lower resistance compared to gentamicin for the Klebsiella. And that's the Bernard study. And just to show you that the mortality rate actually didn't go much except for cefotaxime and amikacin. But the problem is the number of cases that were over these medications compared to the others, and the mortality rates are variable. لكن المشكلة إنه it's not only what you want to do. There's so many other factors that play in what antibiotic to choose. هل الدواء موجود؟ الكوست؟ أيضا microbiome of your local area. في اليمن, do you guys keep tracking microbiome of your area to see what resistant organism here and there? هل في أحد tracking الميكروبيولوجي ويتابع ويسوي studies عشان نشوف resistant, ولا this has been disrupted with what's happening in the whole world? نعم. Yeah. أعتقد إنه حكم إنه اليمن والسعودية قريبين من بعض, we can look لين تتحسن البنية التحتية اليمنية, we can look into Saudi data and try to project their microbiogram على اليمن. And we know إنه تقريبا إنه في high resistance for a lot of organisms. For example, strep pneumo now, first and second generations firstborn and amoxicillin are resistant. So you have resistant. Yeah, that's good. I hope إنه إن شاء الله يا دكتورة خديجة we hear about your study about amikacin, because that is something we would love to hear about. فلعل القادم يا أجمل إن شاء الله يا دكتورة دينا أيضا. لكن ال cost والavailability plays a huge role. يعني مثلا لو تشوف هنا مثلا in this study they look into they don't look into Yemen but they look into different countries. فأحيانا لما يكون تقارن مستوى دخل الناس مقارنة بالانتبايوتيك، بالذات لما يكون العائلة هي اللي تدفع للانتبايوتكس، that is a lot. يعني مثلا في اثيوبيا where I work متوسط الدخل $142. If you're going to put them in amikacin, which is not available actually in the country, but if you're going to put them in meropenem in one dose is $11. يعني إذا بتحطه مثلا على gram negative, which is 21 days, that's going to be more than the family makes in 2 months. Cost play a factor. Some countries, actually the government cover the antibiotics, some don't. اليمن مين يدفع الأدوية المضادات الحيوية؟ اليمن يعني والسعودية متشابهين كثير. السعودية يمكن الفترة الأخيرة they put antibiotic stewardship، لكن one of the reasons زي ما قلت إنه الناس تقدر تروح الصيدلية and just buy whatever they want. relative in the bank. فهذا المشكلة. يعني إذا بنتكلم عن الأميكاسين it's the cost it's 3 times double الجنتاميسين. yes it works better لكنه it's more expensive. Those are things that we have to look into. That's why someone need to look into the resistance of the Klebsiella right now in Yemen, so you can generate guidelines locally for Yemen. إنه إحنا نعرف إنه every nation have different guidelines because they have different genetic background, they have different infrastructures, and they deserve their own data and they deserve their own guidelines. So we cannot rely on the American guidelines because it doesn't work for us. لكن احنا نعرف انه كثير من الاطباء في الدول النامية they don't follow WHO guidelines and they don't use ambingent and they trying to do other things like لما قلتوا على الاميكاسين and ampicillin. لكن في a new clinical trial I encourage all of you inshallah انه you look into it. It's called Neonatal 1 trial. هي الآن ongoing in South Africa and Kenya. They're actually looking into some what we call old new. Old antibiotics ناس كثير ما استخدموها they kind of became new. They have a good coverage for gram negative and they called the fusofamycin and combine it with amikacin or flumoxif with amikacin and flumoxif and fusofamycin. They're comparing the three. The beauty about إنه لما نستخدم شيء قديم من زمان إنه خلاص they lost their patent، فلما صار ما عنده ملكية فكرية the price will be low. فthat we hope this work. And if it works, then it will be a good weapon to have against Klebsiella. But please keep an eye on this trial. I would encourage you to review your own institution's neonatal sepsis rate to see is what we have been doing, has it been working, or our mortality rate is actually high with ambingent, because I don't think ambingent is the way to go in في الدول النامية. We need to think about something else because the mortality rate is very high. With that أعرف إنه عندكم دوامات بكرة ويعطيكم العافية إنه أخذتوا من مسائكم وقت to listen to me. Please, if you have any questions, feel free to go ahead, and I will leave how to moderate the question للدكتور أحمد والمنظمين. I appreciate you all, and I actually I'm impressed with your knowledge. I'm impressed بحماسكم إنه تستمعون لي معه إنه وقت متأخر. فشكرا جزيلا لكم جميعا. Okay. Any questions? Oh, wow.
الله يبارك فيكم إن شاء الله يا دكتور يوسف، أمتعتم وأفدتم، الله يبارك فيكم إن شاء الله. أنا أتوقع إذا في أسئلة من الشباب في الشات.
Okay. في
دكتور
سؤال.
يوسف،
إيه أسمع في سؤال يقول please would you mind making another lecture part 2 because I was busy didn't attend this lecture. أعتقد إنه الزملاء they recorded this فبليز ask for the recording.
طيب احنا ان شاء الله المحاضره بعد اذنكم يا دكتور بنرفعها على قناه تو بي فيت في على اليوتيوب ان شاء الله.
ممتاز خلاص عرفت وين القناة الله
الله
يحفظك.
يحفظك.
طيب في
ايوه
أي سؤال
لكن احنا
ثاني؟
طبعا احنا هذه نعتبرها ان شاء الله اول قطره من الغيث باذن الله سبحانه وتعالى.
أبشر من عيوني احنا حاضرين
الله
أي شيء.
يحفظكم.
أنا عندي أصدقاء من اليمن كثير، وإذا أنتم تعرفون أكثر مطاعم عربية موجودة في نيويورك هي المطاعم اليمنية، فأنا عايش على الأكل اليمني هنا. I consider myself Yemeni by association. I'm more than happy إنه وأغلب مرضاي أصلا يمنيين. I'm more than happy to come back.
الله يحفظكم. في سؤال اللي هو على about السي رياكتيف بروتين، متى يكون بوزيتيف او متى نطلبه؟ يعني اظن تكلمتوا، لكن اذا حبيتوا تفصلوا في الموضوع اكثر.
إيش السؤال مرة ثانية؟ بروتين؟
متى يكون السي رياكتيف بروتين بوزيتيف او متى نطلبه؟
سيلياك بروتين؟
السي رياكتيف بروتين CRP.
C reactive. CRP. CRP has been good and bad at the same time. لأنه CRP can be high, but it's not specific. If the child is in for example, if the child has another inflammation, or the child is in pain, it can go up. فالCRP should be combined مع absolute neutrophil count مع fever and the clinical picture of the child. ودائما احنا نقول للجميع always go back to the basics of medicine. It's history, and physical exam, then add the lab to it. Without a good history, knowing the risk factors, يعني صعب إني أقول CRP is low وأعرف إنه there is a prolonged rupture of membranes. Mom had a fever, and mom had on top of that chorioamnionitis, and had no good prenatal care, and mom ages 40, and this is her 7th child, and ignore all of that because the CRP is low. So by itself has no meaning, but in combination with absolute neutrophil counts and fever and the history and physical exam, it adds a lot. أتمنى أكون جاوبت على السؤال. Right. Is CRP investigation useful when sent within the first 12 hours of birth? Yes, it can. A lumbar puncture, when do you do it? It depends what you're looking for. إذا أنت if you're looking for herpes simplex virus, it's not recommended to do it before 24 hours. Overall, if you are suspecting neonatal sepsis in someone who's just born, or you suspect herpes, so you worry about encephalitis, you don't do the LB at second hour or third hour. You wait until the baby is 24 hours. Otherwise, it's going to be false negative. So for a newborn that you're worried about meningitis, you wait at least 24 hours to do the LB. Is there a rule for corticosteroids? Corticosteroid can be used in septic shock. Hydrocortisone as if you want to use it for inotropes or as vasopressors. If you worry about meningitis before you give the antibiotic and you worry Nemo, it can help with decreasing the risk of hearing loss. But other than that, I don't think there is a role for corticosteroids. Do I have to change antibiotics or step up to a stronger one? Usually we wait at least 48 hours before we add the new antibiotics, because otherwise, if you keep adding, it's gonna be keep changing, because at least any antibiotics takes at least 48 hours to kick in to make any changes. So I wouldn't like start antibiotic today, tomorrow add vancomycin, the next day I'm gonna add a third one. At least give it 48 hours before adding something. Unless مثلا جاني الculture وجاني what is sensitivity, so I will change it to what's sensitive. If the history of a newborn going with early neonatal sepsis, maternal fever, and immediately ask for blood culture, even with 1 hour-old baby. طبعا إذا the baby look well, a recommendation, you can actually, even if the mom has fever, baby look very well, there's no need to do any blood work. You can actually observe the baby with more frequent vital signs. And دائما احنا نقول go back to the basics. A baby who suck well and feed well as well. ما في طفل صحته كويسة صحته مو كويسة ويرضع كويس. So go back to the basics. History and physical exam. Is there a role for common nebulizer for neonate with respiratory distress? There is a new studies talking about that, but I think for low resource settings, we shouldn't consider that yet. So there are no receptors for salbutamol neonates, but طبعا هذا one of the most controversial. It's out of the scope of this talk. لكن يتكلمون عن respiratory distress for neonate. There's a lot of talk إنه ما في enough beta agonist receptors in the neonate airway, but it doesn't mean they don't exist at all. They're not enough, but they are there. هل إنه لو عطيت salbutamol for respiratory distress in the neonate, would they improve? Yes, but are they gonna improve the same as an older child? No, لأنه ما في enough beta agonist receptors, but they are there. They're still there. So a lot of neonatal specialists, neonatology specialists, actually challenging this, and they are using salbutamol when the respiratory distress and they don't have anything else to help with. So they're using it, but it's not as good as when you use it for older children because there's no enough beta agonist receptors. There is some reference mentioned for scoring. Yeah, there is a score system for early onset neonatal sepsis. There's a lot. If people interested in scoring, there's some website called MedCal. It has multiple scores, the Beacon score and many other scores. But MedCal, كلمة واحدة. I'll write it in the chat. And it's a free website. If the history with rupture of 18 hours, should I give him antibiotic? If the child looks well and only rupture membranes, no other risk factors, and the baby feeding well and look active, no fever, I would observe with multiple vital signs, every 4 hours vital signs, and don't do any tests. If the vital signs show any instability, temperature instability, or tachycardia, tachypnea, then I will consider sending CBC, CRP, and a blood culture and decide, do I need to cover antibiotic or not based on the result. Now, if you're admitting for observation to the NICU and the child looks good and you have a nurse that you trust who's going to do a frequent vital signs for you every 4 hours and notify you if something happened, I would just observe. Yes, there is a relation between prematurity and early onset sepsis. The more premature you are, the less immune system you have and less protein, especially if you are low birth weight. We always say 48 hours, you wait before add another antibiotic if the child is not improving. 48 hours, the answer. Every antibiotic needs at least 48 hours for it to work. So I wouldn't jump from the second day to add. Any other question? We have room for one last question. Is there a certificate of participation? Yeah, that's not for me. وإياكم يا دكتورة سحر. طيب شكرا جزيلا لكم جميعا، وإن شاء الله يكون بيننا لقاءات أكثر، وشاكر لطفكم. I appreciate you all and I thank you for having me, and I hope this will spark an idea and make you rethink your approach to neonatal sepsis in your hospital and in your community. إلى اللقاء. إن شاء الله نبقى على تواصل بإذن الله.
شكرا جزيلا، الله يحفظكم يا دكتور ويبارك في ايامكم ان شاء الله وفي علمكم.
آمين جميعا. يلا بأمان الله، مع السلامة.
الله يحفظكم ان شاء الله، مع السلامه.
دكتور أحمد خلاص. لا خرجوا خرجوا كلهم. لحظة.